Thank you for the introduction. So I'm Rahim, says Qazi Muhammad, a very long name. Anyway, so you can call me Rahim. I'm currently working as a clinical fellow at UHCW in the department of HPB. And since morning it has been wonderful listening to all the talks about how we can get the training better. But it's very important to also think about the patients, how the things are going on the patient side. And this has been our #1 priority right from the start at UHCW when we started doing the robotic HPB. We have been carrying out multiple feedbacks, and the first thing we did was to look into how the 12 consecutive Fapel procedures we did. And our plan was to carry out and compare between the robot and open, but due to COVID, we had to stop in between. Our main aim was to carry out an SF36 survey. It was a patient one-to-one face-to-face interview. The bias was removed on the basis the doctors who were involved in taking the interviews were from different specialty and had no previous exposure with the robotic surgery or the HPB team. So that helped us reduce the bias, who were the ones who were taking the interview. All the patients were anonymized. There were 2 different doctors taking the interviews. All the patients were labeled as in the form of numbers and barcodes, just to avoid all these biases. The period we looked at was 3 months post-operatively, and we compared it on 2 grounds. The first one was the time from the diagnosis till the day of surgery, and from the day of surgery till 3 months onwards. Just to have a look at it, how the patient is feeling, what's the quality of life, how have we done good for the patient, has our robotic approach helped the patient improve the quality of life in a short period of time. So we carried out the survey. The data was collected in the basis of SF36, the physical functioning of the patient, the general health. One of the things we added and we emphasized was on the pain, because it's a very good aspect to look at in terms of patient's recovery. Doing an open Whipples, open pendylectomy is a big scar, and then doing a robotic procedure with tiny scars, a big operation, just to see if there's anything different. I won't say that we have compared it, but we plan to compare it in future. But we could see that most of the patients, around 91% of the patients were satisfied and had a better quality of life. If you look at the pain scoring, around within 2 to 3 weeks of time, most of the patients were pain-free. But after that, as I mentioned, COVID came and all this was stopped. Recently, what we have done at our team, we have involved our CNSs to carry out feedback form regularly, so that we can get back into the track again and carry on and gather all the information we can from the patients. That data which my colleagues will be presenting about, and they'll be also sharing a video just to make things a bit lighter. Okay, thank you.
So as a nursing team, we asked patients following major resections, liver and pancreatic, to complete a patient satisfaction survey. We gave them a free text box just to not put words in their mouth and find out what they thought. So here are some of the comments that we got from patients. I think the interesting ones are: seeing smaller cuts on my tummy made me feel like I could cope more. And 2 days after the surgery, I was back home with my wife, which is obviously amazing. The key themes that we found were reduced length of hospital stay, wound healing, and the psychosocial impact of the wounds. So the length of hospital stay. So we know that robotic surgery has a reduced hospital stay, and obviously it's proven that reduced stay puts less pressure on the NHS. When we get the HPV patients, before we actually take them to surgery, we know that they're already hard to manage, they've got lots of problems. Excuse me. They have low muscle mass, obviously pancreatic enzyme insufficiency, some patients weight loss and malnutrition. It's known that patients recover quickly at home in their own environment, and this is obviously achieved by better dietary intake, increased sleep, improved mobility and psychological support from their friends and family. Patients who are at home are less likely to suffer from constipation due to increased mobility, normal dietary routine, increased fibre and less anesthesia due to the smaller incisions. This is obviously all vital for our patients to ensure that they can go on to further therapies and such as chemotherapy. Okay, I'll stand up now, you can sit down.
Okay, so obviously from what we've heard today, robotic liver and pancreatic and biliary resections have made tremendous strides in HPB surgery. NICE guidelines consider robotic surgery to be more acceptable to our patients than open. Obviously they're repeatable and it's safe too. Robotic surgery relies on the small incisions, as we've heard, and it's associated with less pain in our patients, less scarring, less blood loss, and a shorter hospital stay and recovery time. Evidence does suggest that open surgery, as we know, is a big, huge abdominal wound, can lead to more psychological distress, which will delay wound healing and compromise immunity. We know with the pancreatic group of patients that we need to get them onto Quilon ASAP, because those, we actually hear of it quite a lot, don't we, Claire? They're regional. Some patients aren't, and it's until they've had their surgery that we start them on Quilon. So obviously the aim again is to get them started on it as soon as diagnosis, because obviously that can lead to decreased activity and longer rehabilitation time in hospital. Obviously, patients who have less traumatic surgery with a shorter recovery can, as Claire said, get to chemotherapy quicker, and also any clinical trials involvement into that in a reliable and timely manner. Surgical scarring can impact upon individuals differently. Some studies have suggested that scarring can impair social functioning and well-being, and that can cause negative feelings, altered body image, changing our relationships and limit our physical ability. Therefore, in the perioperative period when me and Claire see our patients, we tend to obviously gauge their condition along with the surgeon and see what we need to do to optimise them and their fitness. And obviously there's a lot of patients that smoke and drink, and we can refer out to services to help them with that. So obviously patient education and engagement is essential in that perioperative period, as well as obviously we always support them by giving them information about the operation and obviously what to expect after, during and recovery and after the operation, and support them on their discharge as well. We tend to do post-operative calls, don't we, when they've gone home 3 to 4 days later, and obviously have our contact number if they need to ring us in the interim. Macmillan recognised we need to embed rehabilitation at the forepoint of the cancer diagnosis. As you may, I think we talked about lightly this morning, there's enhanced recovery programmes going on. We know through Pancreatic UK, Greater Manchester already got that embedded, and I know there's some other regional centres that have done that as well. And that's supposed to again aid post-operative recovery in this group of patients. Because what we're obviously ultimately aiming to do is to give back control to our patients and enhance their effectiveness of treatment. Okay.
We're lucky enough to have been supported by the UHCW charity to buy 2 robots along with an ultrasound probe. The charity have created a video about one of our patients, which also includes Jeremy and unfortunately myself. So we're now going to watch this, okay.
Hello, my name is Andrew Carpenter. I've been a patient of Mr. Ahmad for several weeks, probably a little bit longer actually.
I met Mr. Carpenter nearly 6 weeks ago. He wasn't really worried. This gentleman been through a lot. He was unfortunately diagnosed with bowel cancer and had an emergency surgery a few months ago, and was quite poorly off his before operation. Spent 5 weeks in the hospital, had complication. It's quite a large wound. The wound was from top to bottom, and he was given a stoma as well. So he was really worried when he came to see me because the cancer has spread to his liver, and he had some chemotherapy to shrink the liver cancers, and the task given to me was to remove those tumors from the liver.
We
was, or was it going to be successful? I don't really know. But I think what I did, and my wife will tell you, I just trusted them. I was told originally that they were thinking about robotic keyhole surgery. I hadn't really got a clue what that was about at the time. I just didn't know, but when I came home and see Mr. Armand, he did explain what he would do in terms of sending the robot into the body. And I had a bit of a whiz round and had a look. They found all the specs. In fact, they found one, this robot found one that Mr. Armand didn't know about.
So we now have, we can charity bought a new ultrasound probe, and that probe we can use with the robot, and we can scan the liver a lot better. So we scanned his liver with that new probe, and we found one additional tumor that would have been missed definitely if we had not had that probe.
I was back on the recovery ward the same day. That evening, I was out of bed having a walk. And I did on the Thursday, and they discharged me on the Friday, and I was at home by about 1:30 in the afternoon. So it's only 2 days from the surgery, and I was back at home. And there was a bit of pain there, but I mean, it's only 2 days. But I could tell as each day went on, it was getting better.
He had the surgery on Wednesday, and then I went to see him on the ward on Friday to do a post-operative check, which is what we do. And as I went to see him, he'd actually got his bag packed already. I was ready to leave the hospital at this point. We then phoned him as a nursing team on, I think it was Tuesday, and again, he was doing very well, and there was no problems from that point. So the fact that he had robotic resection and trained in a few days is actually really something we should be proud of.
And I met him less than 3 weeks after his surgery, and he just looks wonderful. He has gone back to his normal life. He's eating and drinking normally, no abdominal pain, and moving out normally, looking forward to his holidays. So this was quite gratifying to see that a person who was benefited by the Da Vinci robot has done so well, and we were able to treat him, remove his tumor, and give him a good outcome.
Usually when people have an open liver resection, they'll have a scar from here to here and they get staples. When people have the robotic surgery, they just have the smaller cuts to the abdomen.
I still don't get how I can have all that and just be at home after 2 days and eating and having a cup of tea.
Eating normally?
Yeah, it's sensitive in there. This type of surgery or exploration needs to be funded. It really needs as much money and as much equipment as they can get. And it's a great training exercise because it's filmed, and the number of people extra that can benefit from this type of work has got to be good, rather than the 6 weeks in a ward. Because you've had to open liver surgery, it's only 2 days. I'd want them to raise enough money to buy as many as they can, because it's got to be worth it. It's not all about me, it's about everybody who's behind me wanting this type of surgery, or if they don't want it, they need it, or they should have it if they've got a chance. And if it means as much money as they can get to buy the equipment to do it, it's got to be the way forward. It really has. Because it can't get any better than this, can it?
The most important thing which we can learn from this video is, because if you remember what Prof. Most showed us is heart rate going up. These are things that bring your heart rate down back to normal. So these are very important things, I think, for a surgeon to have a longer life. This is one of them. It's when you see the patient in clinic after 2 weeks' time and you see him, he's fine, no complications have been developed. That's why the patient feedback and quality of life is something we should always focus upon to help us as well as the patient at the same time. And my colleagues would like to conclude on some things, and that's it.
So in conclusion then, patient outcomes are improved after robotic surgery, mainly due to reduced hospital stay, reduced wound healing, less infections and improved psychological impact of the surgery?
We know that there are only marginal gains in robotic surgery at present, but we know that small yet significant improvements in various areas can lead to substantial improvements overall.
Regular patient feedback, which we do to audit our service, will obviously improve the quality of care.
And obviously, looking at all the data, it enables patients to receive further treatment, which is what our patients need. They need to go on, they need to have their chemotherapy and have their further, well, to prolong their lives really, isn't it?
And patient satisfaction when their journey is improved, which is the ultimate of what we're trying to do, and quality of life.
Thank you for listening us.
Thank you.
Patients. Thank you.